Welcome to the Hard Things About Healthcare, where we get into the business and operations of healthcare that clinicians face every day, the challenges they present to delivering care and running clinics, and how they overcome them. The Hard Things About Healthcare is brought to you by Honey Health, the connected care platform for modern healthcare teams. I'm Matt Faustman, type 1 diabetic, and co-founder and CEO of Honey Health.
I'm Ginger Vieira. I've lived with type 1 diabetes for 25 years. I'm a diabetes author, speaker, and content specialist. On today's episode, we are thrilled to introduce Dr. Sumana Gangi, a board-certified endocrinologist and internal medicine physician with a distinguished background in clinical care. Dr. Gangi is the owner of Southern Endocrinology, where she leads efforts in delivering specialized care for a variety of endocrine disorders. She actively contributes to the advancement of her field through membership in professional organizations such as the American Medical Association, the American College of Physicians, the Endocrine Society, and the American Diabetes Association. Her professional interests include diabetes management, obesity, thyroid issues, and adrenal conditions, making her a true expert and advocate for improved patient outcomes in endocrine health. Dr. Gangi, thank you so much for lending your expertise today, and thank you so much just for the career that you've spent trying to improve life for people with type 1 and type 2. So I want to jump right in and ask you, how did you end up in this career path? Why did you choose diabetes and endocrinology?
So part of it is family history. I come from a family of full of diabetics. And when I was in medical school, when I looked around, all my cousins, once they crossed 30, they became diabetic. So my interest in actually not necessarily endocrinology, but the diet and lifestyle changes started when I was in medical school. And there wasn't, I did my medical schooling in India, and there was not much education available for patients to deal with the diabetes. It's a family member tells them that don't eat this because you are a diabetic, because that person has diabetes. It's not like an evidence based education. So that's where I started looking more into the diet and lifestyle aspect of managing diabetes. And also at the time, I realized that if I tell my family members as a medical student, don't eat this, don't eat that, the next thing I realized was they were grabbing those foods that I am telling them not to eat. So instead of saying like a negative way, so to incorporate, you can have this a couple of times a week, or maybe have a smaller portion of it on your plate and replace it with other foods. I learned that, trying to help them out.
Yeah.
Then, when I was in medical school, I wanted to be a gastroenterologist.
Oh, okay.
Okay. Then when doing my residency, I realized that let me do some research into gastroenterology before I choose my career path. So I did a hepatology fellowship in New Jersey. So at that time, I felt like, no offense to gastroenterologists, but I felt like I'm doing more like a plumbing job. It wasn't intellectually stimulating to me.
Okay,
So
right.
I go in, do a procedure, I can see what is there. There is not much thought process involved, to be honest, for me. So
Right.
then I said, no, it is not what I wanted to do. Then I went back to my first love, that is managing diabetes. So I called my professor at Buffalo and I told him that I'm interested in diabetes. And then I decided to pursue a fellowship at University at Buffalo. That's the way my journey to endocrinology started.
Wow. Okay. So your brain really loves all the levers and the tinkering that can happen in patient care for diabetes versus an operation and off they go.
Yes, and also it's very stimulating, right? It's not a straightforward. Not
Right.
every patient is the same. They come in with different things. Even adrenal issues or pituitary issues, they are never straightforward. So
Right.
it's very stimulating. If you make a correct diagnosis, it's very rewarding. And it takes time to come to that conclusion, right? You look at all the pathways, and so I get excited whenever I see a patient.
And
Whether
those
it's
little
even in
moments.
diabetes,
Yeah, sorry, go ahead.
even if it's a diabetes, people say, oh, it's a simple diabetes, but it's not. Each patient is different.
Yeah.
And now we are in an era where we can custom made a treatment for individual patient. It's not like a generic, take this, take that, don't eat this,
Yep.
don't eat that. So it's
Right.
it's I feel like it's very rewarding profession field.
And each patient has their journey of progress in learning how to care for themselves. So I'd imagine it's very rewarding in helping someone get their A1C down, and that's nothing like the next patient who you are helping get their A1C down, right?
Every patient is different, each and every one. They come with their own set of challenges, also with their strengths. It's like, exciting to meet them and help them out to
Well,
lead a better
thank
life.
you for choosing us over gastroenterology. That's thank goodness. So you run an independent practice, which of course involves juggling clinical care, administrative tasks, business operations. How are you maintaining that balance? And what systems or tools have helped your team with that workflow?
So I started the practice in 2016 December, right after fellowship. Like, when I graduated from my endocrinology fellowship in June, end of June 2016, and applied for Texas license and moved from Buffalo to Texas, Dallas, and I thought, like, so starting a practice means you open an office and you see a patient, and somewhere magically the money gets deposited into the bank account. I didn't even know that we have to submit the claims. I was that blind to the business aspect of the medicine.
Wow.
Then we learned the ropes, and some of the things I learned in a hard way. As I said, like, I didn't know I had to submit the claims to get paid. And all that, but I would say it is also like exciting to learn the new things, and also it's more liberating, right? I'm not working for someone else, and I set my own rules, and I can accommodate the patient if I want to see them like sooner, or like I had a more freedom in doing what I do. So if you look at 2016, like at the 2017, 2006, 2007, we have different codes available at the time for patient visits. For new patients, they were coming in as consults because most of my patients were referred from the primary care colleagues. And after a couple of years, Medicare decided that, they don't need to pay consult codes. It became a new patient code. So the reimbursement had gone down, and since then every year the reimbursements are going down, while our cost of running the business has gone up. So in 2007, the average cost for my office help, that includes a receptionist, medical assistant, was like around $12, was the higher end of the pay per hour. Now it's over $20. But if you look at my reimbursements, they're pretty much like, on the lower end of the range. Like, I'm getting paid less, but my expense of running a business had gone up. So to compensate, we end up seeing more patients. And also, like, uh, like, for example, if a patient calls and takes a lot of time over the phone, that is an unpaid time, but it's our time from the clinic. So now we ask the patients to come in, which I personally don't like, because these things can be handled remotely. But handling remotely means it's spending our resources that's not being reimbursed. So to sustain, it's inconvenient for the patients, but we are not left with any other choice. And also, what I did personally was I added more physicians into my group so that we shared the expenses. So the fixed expenses will be shared among the different physicians. So
Yep.
that helps to leverage the cost.
Okay.
Yep.
And in a few, like, 4 or 5 years ago, we started an offshore team too, to see to do the back office work remotely, because the cost of human resources there is one fourth of the cost in US. So we thought we can hire more people and do the work so that we can streamline our clinic flow. So I have to say, like, we have a very well oiled machine. Our operations run very smoothly. But day to day we do have our own challenges. So lately it's been like keeping the staff. Like, there is a high turnover since COVID, for reasons I couldn't figure out. I'm still trying to figure out, I should say. But that's been a biggest challenge. And also with the insurances, like back in those days when I first started the practice, I felt like I'm like I have a what should I say, I'm ruling, like I decide what to prescribe to my patients, and 90% of the time it goes through. Like now, only 30% of the time I have that choice. I choose, like okay, my patient benefits from this medication, and insurance says no, your patient doesn't need it, and they don't know my patient, right?
Yeah.
And
So
it's very
frustrating.
frustrating. And now we have a full-time resource just doing prior authorizations. That's an added expense.
Yeah.
Wow.
But we can do prior authorizations on our own, and sometimes people the insurance is peer to peer, and then they give us a number to call, and we call them, and it goes through a voicemail, and we tell them to call us back, and it goes to our voicemail, and we are playing a phone tag. It should be a simple process, right? I'm a board certified endocrinologist, been in the field for almost 20 years, and if I decide that my patient benefits from this medication, there shouldn't be any questions to be asked, my medical decision. And half the time, more than like half the time, my peers are not the endocrinologists. They are not even the internal medicine physicians who deal with the diabetes and other hormonal issues. They are chiropractors, they are podiatrists, and sometimes I even got a physical medicine rehab. They have no clue what the diabetes is about, and how can they make a decision about my quality of care without treating those kind of patients.
Yeah. There's a lot there to talk about in terms of running an independent clinic, from prior authorizations to staff. I want to talk a little bit about staff turnover as one topic here, because this has come up in so many conversations that we've had with large health systems, with independent clinics, and it seems like it's been a major issue since COVID. Any hypotheses of what might be happening there, and what are some of the things that you and the team are working on to try and minimize the turnover with staff, because this is not an isolated problem. It really seems like it's a major ubiquitous problem across the industry right now.
So, like up to till COVID, right? Most of my staff has been with me for more than 10 years. Yeah, I would say 80% of my staff. And then when the COVID hit, they had this law that, if they get paid certain amount, they don't have to work, kind of a rule. I don't know the exact name of that thing. The COVID benefit was like, they get paid by staying home instead of coming to work. And at that time, 90% of my staff walked out. And then we had to, like, but we opened the clinic, we were not doing telemedicine, we were like open, we are up and running, so we needed staff, right? So we had to offer a higher salaries and retrain the staff, like it's not retrain, we need to train them, because these are not the people that were working in like medical field. And then since then what I seen is people move around a lot. Like if I have a medical assistant who's been with me for a year, and if there is an hospital or some health systems that are in high demand during summer months, like flu season or whatever, they offer a much higher salary that I cannot compete with, and they move.
Yeah.
And then, but those jobs are very short-lived. After the demand is done, they let them go. So then they're back to the like looking for jobs. So once, like we realize that they are offering a higher salaries, but we realize that it's only for short term. They are trying to hire these people. We have that data when staff comes in and say, "Hey, I got this job opportunity. They are offering this," and I show them, "Hey, this is what happened a few months ago. They offered more, but they kept the employee only for a few months, and now they're back to asking me," because I have the communication from them saying that, "Dr. Gangi, I want to come back and work." So that helped. And also we try to have a more like a closer relationship with our employees. and we are offering the healthcare benefits. We make it more like a family unit. We take them out. We do like, the bonding workshops and things like that, and that helped. But it's still a challenge. And also cannot explain why the quality of the employees has gone down. Is it because we are desperate to hire and hiring people that are not well qualified, or the people really don't want to work anymore? I'm not sure. I don't have an answer for that. But it is like, it's from the same schools we are recruiting from, that we did before, but the quality has gone down. So it's a day-to-day challenge. We try to navigate it with whatever the options we have. But what I realized is the more closer bonding we develop, like with my MA, I talk to her. Sometimes I bring her a coffee from Starbucks, or like, Starbucks, or like if we have a lunch sponsored by the reps, I tell them we never make the decision what lunch to bring. I tell my staff, hey guys, you guys make the decision.
Yeah,
It's for them,
that's great.
like, whatever they want to eat, and those kind of things, and they feel like they are valued more. Then I feel like they tend to stick around longer time.
Yeah.
Yeah. Yeah. I mean, recruiting, developing, managing great employees
Yes,
is a hard thing,
it's a
right? But
full-time
it's
job
so
itself.
yeah, and it's so critical for running a clinic, a small business, a startup. It really comes down to the people. Kind of switching topics here, but we went through a number of things that you have to do as an independent clinic to just run, right? And it's all on you, right? There's not these massive administrative staffs to support it. How do you balance that with building relationships with and engaging with patients, right? Like, how do you not let the administrative take away from the patient experience, who are your customers, right? Like, how do you balance those two things?
So I always tell myself that I'm a physician first and the business owner next. So my top priority is my patient's well-being. So I generally don't, when I'm seeing patients, I don't think about the administrative work. And also we have an office manager now. I delegated the work. Before I used to micromanage, like, I don't want them to send the statements to the patients. I didn't want them to ask them about their balances when they come in. I thought like it is disrupting the professional environment. Like, but now I don't involve in those. Let them do their job. I supervise. I don't micromanage anymore. But my job is to see the patients. And it is there. End of the day, again, it's a business, right? And it has to, like, we have mouths to feed, and my staff, I had to pay my staff. So, but what I realized is if my professional part is taking over the business aspect, then I'm not doing a good job, good service to my patients. So I separated them. If my office manager or administrative person says like this patient has certain amount of balance, we have to collect it before we see, I'm like, that's a new policy. Like, but we come up with the new policies very early on in the year, and we inform the patients what's going on. um, and that's the way we've been running for last couple of years. Prior to that, I didn't want that way. But we have to, as I said, like, mm, to run a business, I decided that, let like, delegating the task and let them do their part and let me do my part.
Right, right. So another big part of managing your patients in a diabetes clinic is managing all of that data. How does being an independent clinic impact your ability to collect and interpret and act on all that patient data compared to a larger healthcare system?
We use electronic medical records. We have e-clinical works, and we have the data there. So it's an ever changing, right? Like, the Medicare quality data, or like, the insurance quality data keeps changing every year. So we
Yeah.
created templates that way we can identify those points quickly. like the A1C, eye exam, feet examination, flu shots, pneumonia shots, kind of those things. And I update those templates on a periodic basis. And that way I have that information. But once the patient comes into the clinic, we have a very like a smooth process. The patient checks in depending on their diagnosis, if it's a diabetes. Are they on insulin pump? Are they wearing a continuous glucose monitor? Based on, or like, do they have a glucometer with them? Did they bring their medications? So the front desk will update their the pharmacy, and when the patient is ready to be seen after checking in, my nurse will download all that information. So the front desk communicates the medical assistant saying that this patient is on the pump or the CGM. These are the medications. And then they go in, they verify the meds, they download their insulin pumps if they are on insulin pumps or continuous glucose monitoring. And they also ask about their eye exams and if they are done or if they are due, what can be done. And those information is already there when I walk in and to the patient's room. So
Okay.
we focus on, like, if it's a poorly controlled diabetic, I'm not going to insist on them going to get their eye exam checked. I'm going to talk about their high blood sugars, why it is high, what can be done. Is there one change that they are willing to make? Let's work on that. I don't give them 10 different things for them to do. They are already overwhelmed. Like, so if the come in with very high sugars, the priority at that moment is looking at their blood sugars and see how we can bring it down.
Does managing and accessing all that data, that sounds like that is nearly a full task for one nurse, right? Is to access and
We
get.
have like a couple of people working on that for all the physicians and advanced practitioners in our group. So they download, all they do is downloading. That's why that's an added expense, right?
Yeah, it's a huge one, right? Because
And
it's
then
so
my
time
nurse
consuming.
goes in and she verifies the medications, talks about the quality, the other standards of care, like the eye exam, if they got the flu shot this year, and when was their pneumonia shot, and things like that. And that is documented in the chart. And because we use the templates, so it's easy to look for these findings. And I generally don't like to type or document anything when I'm in the room. So I talk to the patient, and then I come out and I make certain changes like their medications. I send the prescriptions. My note is not done. So I spend my evenings and weekends charting to
Yeah.
complete the notes. So that's what I did for last 14, 15 years. And the beginning of this year, you said, like, I'm working 7 days a week and more than 12 hours a day. So my work wasn't done when I leave the office. I'm carrying the work to home. So I now have a scribe, and she types the majority of the note, but I still review and complete
Okay.
that stuff.
So that's another added expense. You've hired a
It
scribe.
is.
Yeah.
But now I log in the evenings to review the labs and certain things. I don't need to worry about the charting and not filing the claims on time because my notes are not done, or my
Mm,
referring provider is still waiting for my consult note and things like that. So that
right.
part is better. But
Right.
again, it's an added expense. Some of the clinics recommended to use the virtual assistants for scribing. For some reason, um, I wasn't comfortable, and I thought like the no patients were not comfortable either because when I walk into the room, they know me, and if it's a new patient, I introduce myself and then I introduce my scribe. Even for a follow-up patient, even though they know me, I tell them, hey, I have a girl here, she's will be typing, she is my scribe, and they are fine with that. And if I have somebody remotely on my computer listening to this conversation, I'm worried about the privacy part. Even though I'm saying they may be HIPAA trained and HIPAA certified, somehow that thought is still foreign to me, so I'm still like having a difficulty with that thought process. So
Mm.
we have a real scribe with me in the room. That, of
Okay.
course, is an added expense. So
Yeah, absolutely. Have you thought about any of the new AI scribes? I mean, there's a dime a dozen now that are out there. I literally every week I feel like I see a new AI scribe,
Yeah.
and I'm sure you probably get emails every week from
Yes.
these. Is that anything that's interesting to you in terms of helping to at least get the notes recorded, or did the same questions start coming up for you in terms of how the patients would feel about that?
So the AI probably will work, but I felt like it is not very personal, right? When I'm like, we have the AI built in with the eClinical Works, and it's now live, it's activated. I tried the conversations. It seems like it is very robotic. I'm not sure what's the right kind of word to explain that. It looks like it's a chat GPT generated conversation, like with all this very like high profile wording. We don't talk about I am for example, uh, what should I like some of the simple words. I ate this sandwich, that's why my sugar is high, versus I consumed from a fast food restaurant that elevated my blood sugars to 600. I felt like it's very, I'm not sure, I think it still need to be more evolved. um, Sometimes I use it for for the treatment part, increase the dose or stop the medication, start a new medicine kind of thing in my treatment plan. But the beginning of the note where I'm having a conversation, I still prefer it in a manual entry way.
Yeah, yeah, that makes sense. That totally makes sense. Yeah, I'm curious. We talked about the patient experience, and you wanting to make sure you're doing right by the patients. And one of the things about independent clinics is you have the advantage of being able to build more personal relationships with your patients. So I'm curious, how do you approach building those relationships with your patients over many years? Are there techniques or tools that you've used to help you keep track of everyone and to build those relationships, whether they be technical or just things that you do as a doctor? Curious, like how you think about building those relationships for the long term with your patients.
So since I started the practice, um, whenever I see a new patient today, definitely I will have a couple of new patients in next couple of weeks from that patient, referring his family members. So that's why if you look at my patient profile, a lot of my patients tell me that I'm their family doctor, because I see different members of their family, but they have different PCPs, primary care physicians. So I think it's because of the time we spent. And as I said, I don't look at my computer when I'm in the room. I don't like to do that. It's actually convenient for me if I can just type while I'm talking to the patient, but I feel like it is interrupting the relationship, or something else is coming in the middle. I want to look in their eyes. I sit down and talk to them without any interfering stuff. I review the labs with them if they had done the labs prior to their visit, or if I'm ordering new labs, I tell them. Or I'm reviewing the prior labs, I say, hey, this is what it is, and I show it to them. But I don't like to type and some people look at the patient and then they chart, and somehow I'm unable to do that. I personally don't like it, so I never ventured into it. And I think that helps, because the moment, a lot of times my patients wait for minimum of 30-40 minutes to see me. I feel very upset about it, the time wait times. I've been working on improving that, but when I walk in, it's my time with the patient. I feel like, it's a privilege, and they're allowing me into their personal space, right? They talk about their issues and all. I don't want any other distractions. And I think if we, even a shorter time, if we do that, uninterrupted conversation, I think that helps to build the relationships. And being more like, little more empathetic. And I know we are all rushing from one room to the other room to get our volume or to see the numbers that are required. But on the same note, if we have a few minutes just to listen, I think that helps a lot. So a lot of times when we ask the patients, right, why their diabetes is not under control, we tend to assume things like, okay, they are not taking their medications, or like the medications are super expensive, they cannot afford. But a lot of times there is a personal component too. They may be dealing with something that is like took the priority over their own health. That those kind of conversations won't happen when I'm charting and looking at my computer, not looking at the patient. But when I'm looking at them and those things come, like, they like to share those, and then at least we can address that.
Yeah.
And if they don't share that, there is no way for me to address those. I think those few minutes of, like, undivided time, I think will help to build the relationship.
I would say with my endocrinologist, she spends the whole time at the computer, and I don't feel like I have a relationship with her at all. So thank you for your approach, because I know it creates more work for you at the back
It
end.
is, but as I said, it's more important. So, like, I can proudly say more than 75% of the patients have an A1C less than 7%. So we meet those metrics.
Wow.
That's because
That's
Wow.
we
incredible.
have a
Wow.
relationship. And some of the patients, they tell me that, don't scream at me or don't get mad at me, because they know I get very serious if their sugars are high. So that kind of communication to happen, we have to give the time, let that to undivided time.
Wow. So, what do you see as the biggest opportunities for independent clinics in endocrinology? And how do you think innovations in diabetes management and diabetes technology could empower smaller clinics to thrive and deliver excellent care like you are delivering to your patients?
So actually, a couple of days ago, there was a data about 80% of the counties in United States doesn't have an endocrinologist. So with that kind of shortage, and our field is in high demand, we don't need to work for bigger health systems. Like, once you join a bigger health system, you are mere an employee for them, and you will come under the category of a provider, not a physician, right? So that changes the dynamics, and I'm not chasing the numbers. Here I'm independent because I want to be independent. I feel like that way I can provide the better care for my patients. And also, there are a lot of things I don't have a five managers over me managing me. I don't have an like, we have an office administrator. We don't call them as an office manager,
Right.
but they are not bossing around me, telling me what to do. And
Yeah,
then
and
I don't
telling
have
you how to
honest.
be a doctor. Yeah.
Yes. So that helps. And also nowadays it's a technology. It's easy, right? You download their CGM even remotely. If I have a patient that like, patient that's wearing a CGM, my staff, when they come in, or if they are waiting for the rooms to be available or the patients to get checked in, they download this data. So I walk in, I have all the information that I need. Like, and I look at their blood sugars, I look at the meds that they are on, and then it makes it easier to streamline their treatment. Like, they come up with a treatment that works for them. And also, like, this is a golden era for endocrinologists or anybody that deals with the diabetes. We have so many miracle medications. It's not just insulin, metformin, and sulfonylurea.
If you can get those medications covered
That
by
is
their
the plus.
insurance, right?
So these are life-changing medications out there, and it also makes our job much easier. So my goal is, every time I see a patient that where I prevented a heart attack or a limb amputation, I, like, that is a reward for me. Those are the things I strive for. Like, a lot of times people come in with their foot ulcers and they were told that they need amputation, and we tell them, okay, let's wait until your sugars are better and then let's see. And then the things get better and the wounds start healing, and we avoid the amputations. So
Wow.
those kind of things. And also, like, we do send the patients for screening for their cardiovascular risk. And if they find a blockage, we are preventing a heart attack. The goal is not to develop a blockage, but some of the things are genetic. So if you manage their diabetes, their lipids and blood pressure, give them the appropriate medications, we are going to minimize the risk. So I think that will help. And as I said, technology is there, but as technology, we have to use it with caution. It doesn't replace us. So I don't think AI will ever replace a physician. But, like, we have to utilize it for our own advantage. So if I can have a patient, if that like we see a lot of pregnant women with a gestational diabetes, I can't have them come in every week to my clinic. But now with the CGMs, I download their CGM, and then we send the recommendations through
Yes,
the portal. Yeah,
great.
it's unpaid work. Sometimes we ask for televisit if I have to make a lot of changes. But if it's a simple, like increase one dose, then we just send the portal message. So those things will help too. So that's
Yep.
why I don't see a reason to join bigger health systems and clock
Yeah.
in and clock out like a.
Right. Well, I know we both appreciate, and I'm sure all your patients appreciate how much you have had to persevere and adapt to all the challenges that are in front of you, and all of these added expenses that you've needed to embrace in order to provide excellent patient care, which you're clearly providing based on everything you just
Thank you.
shared. So thank you. I mean, yeah, thank you. We need more clinicians like you.
And thank you. It's a lot of work, but it is at the same time it's rewarding. If they let the doctors be doctors, I think we will provide a better care. But
Yeah.
Yep.
unfortunately, that is changing.
What a crazy idea. Let the doctors be doctors.
But the one thing I would say is, at least if the insurance agrees with our treatment plan, and instead of putting a roadblock saying, like, creating more hurdles for us to prescribe what we would like to prescribe for our patients, probably we would do even more justice to our patients.
Yeah.
Yeah. Well, I think insurance right now is under several microscopes, and there's a very just this morning in the Wall Street Journal a pretty interesting takedown of a lot of insurance practices, et cetera. So I would not be surprised if we see some pretty big changes coming in the next several years, because it feels like everybody from employers to individuals to doctors are not happy. People do not feel like the system is working.
Yes, I hope so. I hope for a
Yeah.
positive change in the
Agreed.
Yeah.
coming years.
Yeah.
Agreed.
Well, thank you. I know we're at 50 minutes and we so appreciate your time, Dr.
Thank
Gangi,
you.
and thank you
Thank
so
you
much.
for having me. It's a great
We love
conversation.
having entrepreneurs on and folks that are building their businesses. It's absolutely amazing. So thank you so much.